Well, good morning, everyone, and I'd like to welcome you to the West Health Institute and welcome you to our first West Health Idea Series, where we bring together thought leaders in healthcare to discuss how we can address the cost crisis in healthcare, the central mission of all of us here at West Health. My name is Nick Valeriani, and I have the distinct privilege to be the Chief Executive Officer of the West Health Institute and the Chief Executive of West Health. And for those of you not familiar with West Health is an initiative combining four separate entities. The West Health Institute, where we are today, our West Health Policy Center in Washington, D.C., our West Health Investment Fund, focused on investing in early stage companies, mission aligned to reducing the cost of healthcare, and to our West Health Incubator, where we look to launch new companies. And very excitingly, we have recently launched two companies into the West Health Incubator, our Sense for Baby company and Reflection Health, all acting under the central mission to lower the cost of healthcare by creating innovative, patient-centered solutions that deliver the right care at the right place at the right time. Our organization was initially founded 3 years ago as the West Wireless Institute. And talking with many of you this morning, I think that's how you've come to know us. We were founded by the pioneering philanthropists Gary and Mary West, who to this day are our sole funders, making us independent and nonpartisan. I'd like to also start our day by introducing some of the leadership team here at West Health. First, our Chief Financial Officer, Mike Capinetto. Where did he go? Did he leave? Dr. Mo Cashel, our Executive Vice President of Business Development and Chief Strategy Officer. And Scott Cassidy, our newly appointed Executive Vice President of Technology-Enabled Care Coordination. This is a very exciting time for all of us, which is clearly tied to our subject today, and how West Health engages, innovates, and develops solutions that disrupt the process of healthcare to lower the cost of chronic diseases. Today, however, we're going to focus on how wireless is being used to transform healthcare by enabling new innovative products and services, enabling mobility inside and outside the hospital, and driving down the cost of healthcare by enabling infrastructure independent care and data democratization. West Health has been working on this problem for several years now. And we're very excited today to have experts from our West Wireless Health Council here to discuss new healthcare facilities they have built in the local area. These facilities have included a medical-grade wireless utility into their hospital, a concept being championed by the West Wireless Health Council and the West Health Institute, and being made available to all healthcare systems across the nation. At this point, I'd like to introduce our panel of experts. First, Paul Peabody, who is the Chief Information Officer of Palomar Health. Welcome and thank you for coming. Brian Rainey is the Corporate Vice President of Facilities Design and Construction for Scripps Health. Bruce, thank you for joining us. And our moderator today is Ed Cantwell, our Senior Vice President of the West Health Institute, who leads our medical grade wireless initiative. Now, one more thing before I turn it over to Ed. Our communications department would have my head if I didn't make sure to keep you involved in the digital conversations we're going to have. So please use and follow #WestIdea. And for those of you old to me who thought the hashtag was a pound sign, use that to engage in the conversation on Twitter. And follow us at West Health for more information. We'll be posting video of this event very soon. And again, on behalf of the entire leadership team of West Health, thank you for joining us this morning, and let me turn the program over to Ed.
Thank you, Nick. Everybody hear me all right? First, I want to thank our communication team for putting on this breakfast. It's a phenomenal venue, and I appreciate their hard work. Also wanted to thank the diverse group that is here today. We have two hospital executives, but By last count, we have hospitals represented, Scripps, Palomar, UCSD, Kaiser Permanente. We have probably the leading medical device vendors in the world, GE, Philips, Mindray. We have new innovative companies like Cetera, and you saw their product out there. We should have a carrier in the crowd. Shall remain nameless. We have one of the leading power companies, American Power, in the audience. We have representatives from Gary Mary West Foundation, technology contractors, press, Nokia, and some of the best chip manufacturers. So what a great, diverse ecosystem. We are thrilled to have Paul and Bruce on the stage. And San Diego is incredibly fortunate to have these two gentlemen leading the charge at both Scripps and Palomar. If you've not seen the new hospital, it's phenomenal. If you don't recognize the new hospital going on across the street. So we want to thank each of you for being here. Why don't we start out by just saying a few words about your background and so, Bruce, why don't you go first?
So I am Bruce Rainey. I'm the Vice President for Construction for Scripps Health. And many of you would look at me and say, well, why is he sitting there? It's a construction guy. This is a nail and hammer kind of guy. But in the last, I would say, 2 years since Ed first contacted me and started to talk about this idea of converged wireless and owned wireless systems that would drive down the cost of healthcare, I've come to learn that my partners are in IS, and that we together can create a system that allows us to create a better environment, not only for the building and for the people who use the building, but for the systems and processes and equipment that will be in the building. Recognizing that in past years we have been tied to products that brought in their own infrastructure. We're changing up that model to look at how the infrastructure now is independent of the product, which allows for flexibility of movement in healthcare and allows us to then make the appropriate selection of equipment based upon clinical needs, not solely based upon capital needs. So I've become, I guess, entrenched in the process and the process owner really with IS in pushing forward a new technology into our buildings that heretofore we have not had the opportunity to do. It does change that model. Having the opportunity to do so from a construction side allows us to use that construction funding, that capital funding, to really push forward what we see as the future. So I do appreciate Ed coming forward and West Health coming forward with the idea and bringing that information to us. We are very fortunate to have them just across the road from our offices so that we can collaborate in all ways. Thank you.
Good morning. When I look out at this view out here, I don't know how they get anything done. The ocean's that way, and the golf course that way. It's pretty phenomenal. I feel very fortunate to be in the San Diego area. I've been here for 2 years. Came here from Michigan, where it's awfully cold right now, and I love it here. But had some great experience here just in a couple of years that I've been here. And I would be remiss if I didn't acknowledge and introduce our CMIO, Dr. Ben Cantor, who's sitting in the audience here. Dr. Cantor has been instrumental in helping us move technology at Palomar Health and moving it forward, and especially helping with the design issues and challenges in this new facility that we just opened up. I think we're at the crossroads here in healthcare. The next 5 years are going to be unbelievable. I think that we're going to get turned upside down. Everyone, from payers to providers to patients, we're going to get turned upside down. And I think that one of the game changers in healthcare is going to be technology. I think it's finally going to be technology. We've talked about the promise of technology over the last, I don't know how many years. I've been a CIO for 32 years now. That was before that career is over. And I spent 30 years as the CIO for Beaumont Hospitals in Michigan, a very large healthcare organization, and had the opportunity there to open a hospital, to acquire and integrate a hospital. But I'd have to say that none of those experiences were anything like the opportunities that we've had and I've had in the last couple of years with opening this new facility. And I came a little late to the dance because the construction process started in 2007, the design process I think 3 years before that. So a lot of work went into it prior to my arrival, but I did have the opportunity to influence a few things and to be a part of the team, which has been a phenomenal experience for me at this point in my career. The hospital is the new hospital that
there's a picture of a beautiful hospital.
Yeah, the hospital that we opened up on August 19th, 3 months ago, is very unique. It's been touted as the hospital of the future. And when we say that, it's not so much that you'll walk into that hospital and you'll see phenomenal technology, because you won't. I mean, we have an infrastructure that's going to lead us forward, but what you'll see when you walk in to the hospital are some very unique design concepts. This building was built according to LEED certification standards. We are not LEED certified, didn't want to put the money into actually getting the certificate, but it was built to those standards. We could be certified. But the other unique part of it was that we partnered with the Center for Healthcare Design in building this facility to utilize experience-based design concepps that were, and this was developed out of Dartmouth in the late 90s. There's a concept called the Fable Hospital, if any of you are aware of that. And the Fable Hospital is about 14 different design concepts that are very unique. And there are hospitals around the country that over the last 10 years or so have incorporated one or two of those concepts into their design. We comprehended almost all of them. So almost all of the Fable Hospital concepts are in this bin. And what those are, I'll just throw out a few for you. One is that the patient rooms are very, very large. They are same-handed when you walk in, so everything is placed the same way. The bathroom doors are double wide. The bathrooms are very large. There are railings that lead from the bed all the way through and around the bathroom facility. There are no nursing stations, so the caregivers are stationed closer to the patient. One of the things that you'll notice when you walk into the hospital and you walk through the floors, you can hear a pin drop in many cases. It's very, very quiet because of that. There isn't this dull roar that you normally hear when you walk through most hospitals, and walk through our other two hospitals. You'll hear that, but not here. So no nursing stations. It was built to be acuity adaptable. Now, we couldn't do that because the CDPH wouldn't allow us to do that, but it is built to be acuity adaptable in each of these rooms. So many different design concepts that were built, and then we try to support that with technology, because obviously without nursing stations, we have to do something to be able to connect all of the caregivers together. And so we use technology to do that. And I have to say that after 3 months, is everything working perfectly? No, it's not. Will we get there? Yes, we will. And I think that Once we do, we're going to have some phenomenal experience to point to and some phenomenal achievements. But we're still working our way there. It takes about a year or so to settle in a brand new facility, and it's going to take every bit of that year because we have turned the world upside down for a period. I mean, it's entirely different in terms of how they provide care because of this facility. So interesting times ahead, but it's been really exciting.
Thanks, Paul. So to ground the discussion, Nick challenged us the other day to describe to your mother what you do. Pretty tough in some of our jobs. So I told my mother, who's going in for a hip surgery, I said, you know, Mom, my job is to make wireless work in the hospital. And she said, okay, I'm going there on the 4th. She's 79. She just bought her second iPad because she wanted the retina screen. She said, well, I would expect it to work, you know, when I'm in the hospital bed. So that is the mission, to make wireless a medical-grade utility, just like electricity, plumbing, and heated and cooled air. So these two gentlemen are on the opposite spectrum. Bruce built them, and you just heard Paul, you know, eloquently talk about how he uses technology as a means to an end. So what I'd like to do is to ask a few questions to cover, you know, the progression of good design to the implementation of wireless. And I'll start with Bruce. He's going to be sitting in this chair in what, mid-2015? Presby Tower?
Yes.
Yeah. So if you go across the street and you see the 7-8 story building, that's the new tower there. So Bruce, from a design point of view, and the reason why we latched on to Bruce is if you can get early in the design, you can design wireless in. If you don't, you got to bring it in after the fact. So Bruce, say a few words about the design part of it.
Well, you know, from the get-go, when we started this conversation, not being an RF engineer, you really don't understand what that means to the building. So when you start to look down the path of what the building means to the wireless systems in the past, I was building buildings, and Mark Weisenberg, my cohort sitting here on the side with IS, was installing the wireless systems in those buildings, and we didn't need to talk to each other. Basically, I provided a building, he figured it out after we built it, whether or not it had the right caricature to support what he was doing. And in looking at the technology of the future, we now are joined at the hip, if you will, and looking at the architecture of the building. Simple things like full height tile in a bathroom blocks that RF signal. Would my architect have known that? No. Would I have known that? Not until Mark informed me of some of these characteristics of the buildings. And so looking at the building itself and knowing that a modern hospital with massive amounts of steel and concrete, especially in California relative to the seismic codes, our building naturally blocks those signals that we want to now carry throughout the building. So understanding how the design and the architecture will affect those ultimate build-outs, those ultimate solutions for our wireless technology becomes more and more important. And that's part of the reason that the conversation does continue as we look at how do we properly design a building. Interior designers sometimes may be the ones who don't recognize that and can impact it the most. If you're using foil-backed ceiling tiles, if you're using, as I said, the tile in bathrooms, various products that we use in the building have to be considered now, or you have to increase the density of the system, adding cost to the system itself as well, therefore fighting the opportunity to lower the cost. So understanding that, being cognizant of it, bringing that information to the entire design community, it's a difficult situation when, in our case, we have 150 active projects at any one time. trying to spread that message, if you will, throughout the entire design community for all 150 projects becomes the challenge. So it's a conversation of the future. It's a conversation that goes on relative to all of the aspects that you have to work towards. And it's a difficult one. It isn't easy when people are used to doing construction, doing designs in a certain way, to explain to them why it matters. Why does it matter? What it looks like in a room that nobody thinks they're going to be using the technology in. And we know that it matters because it will block it from accessing the next room over. And so we really do have to pay attention to that and spread that message. That's probably the most difficult part of this. Building the infrastructure for the building itself is not the most difficult part. Designing where is the hotel going to be, how is the system going to be put into the ceilings, do we run on coax, do we run on Cat 5, Cat 6. Those are, if you will, more simplistic, and they're based around the system itself, but understanding the complexities of the building and what it does become the antithesis to what we're trying to accomplish many times.
So, Paul, one thing that impresses me about his new hospital is the design of it actually shaped the workflow of it. And if you listen carefully, it's changing the workflow, which is probably the hardest thing to do. So from a design point of view for the new hospital, Paul, would you have done anything differently if you could roll back the clock and start from scratch?
Well, yeah, sure. You'd always do things differently. And I think what we needed was time, unfortunately. We rushed to pull together some very complex systems in a very short period of time. And I wish we had had the time to run a few more pilots in our other two hospitals first to get some experience, but we didn't have the time. And let me describe what the challenge is and what the issues were with that. One of the primary systems that we put in place to take advantage of the infrastructure and support the new design was in the area of nurse call. I talked about no nursing stations and having to use technology to bring together the caregivers in terms of that communication that we were going to be lacking because of decentralization. And so, traditional nurse call systems, you got a button on the bed, you press the button, and that alert goes to the nursing station. And a unit secretary probably notices that a patient in room 8205 needs something. So they try to find the appropriate nurse that cares for that physician or the nursing assistant. Maybe they don't find him. Maybe they can't find him. Or maybe they find him 15 or 20 minutes later. Maybe the patient got the service. Maybe they didn't get it at all under the traditional system. Well, we changed that. And so we implemented an advanced nurse call system that maintains a schedule for every patient. So you've got the nurse, you've got a backup nurse, you have the nursing assistant, and you have a charge nurse that are assigned to that patient. That's the master schedule. Then we worked with a vendor that provides middleware to route that information appropriately. And then we connected various systems through that middleware. We connected teletracking for bed management, for transport. We connected the order entry system, our electronic health record system, so that we could capture that information and route it. We integrated telemetry, so our Philips telemetry system is integrated through that middleware. And we integrated our communications through our voice over IP system. So we gave each nurse and the assistants and caregivers a wireless phone, so Cisco wireless phone. Connected that all together so that and connected the nurse call system through the Hill-Rom bed with a pillow speaker that allows the patient to press a button when they want water, when they want pain medication, when they need assistance to go to the bathroom. And so let's say it's a request for water, so they hit the button for water, and that's routed through the middleware to the nursing assistant, not to the nurse, to the nursing assistant, because that's something that a nurse shouldn't have to do. So that communication goes directly to that nursing assistant, and an alarm goes off on their wireless phone. So that service is provided very rapidly. Now, if they don't respond, then it escalates. And so it'll then go to the nurse, it'll go to the backup nurse, it'll eventually go to the charge nurse if that service isn't provided. But there are challenges with that. I think that nurses feel tethered now. I mean, and we over alerted. As most people do when they start these systems, we over alerted, and we were driving them pretty crazy. And still are to some extent, and we've got to fine tune that. But the opportunities are phenomenal. I mean, the telemetry, being able to alert for certain thresholds. One of the things that we're going to do is very exciting. It goes back to the design, and I didn't mention this part of the design, and we're going to tie it into this system as well. One of the design concepts that's really, really, really cool is the healing garden concept that we have in our hospital. If you see that glass structure that protrudes from the middle of the building. That is a garden on each and every floor that's open to the outdoors. So it's partially enclosed, partially open. Has a lot of plants and trees, and it's a very, very aesthetically nice place to go. And there are studies that have shown that patients that can get into those environments heal faster, use less heavy medication, a lot of benefits from those healing gardens. But the issue is that when those patients go out in the healing gardens, we want to be able to monitor them. We want to know what their condition is. Well, we're working with a company who happens to also be in the audience, Gary, Sotera. And actually, Sotera hit a milestone yesterday. The first wireless patients our pilot project in Colorado happened yesterday. So first patients that came up on this. We're going to take that to this hospital so that we can monitor their blood pressure, we can monitor their vital signs when they go out within those healing gardens. And so we'll know, we can alert then the nurse through this middleware when something's going wrong so that we can respond to it. And that's pretty neat as well. We'll probably also have to leverage our RFID capabilities as well so we can locate the patient and know where they are. And we have that built in to the infrastructure as well, to be able to use RFID for location. Today we're just using it for monitoring temperature, but we can get to people and things pretty quickly, and we're going to do that. But we'll tie in that monitoring into that as well.
Thanks. You can tell Paul's pretty passionate about the great work that's been done. Let me switch pictures here. This is, I don't know if this is a 2015 or a 2020 look at your hospital, Bruce, but Bruce has the... all right. You want to play this game? Let's do it. Tell me what that is.
It's our tower out in front of us.
Oh my, you're a cheater.
So simply, that is at the intersection right outside of our building. That beautiful tree with the bolts at the bottom. Has three sectors that point down each road, and all of the carrier equipment is in that hut. So this leads to, how in the world do you get that into that? Because 70 to 80% of all PCS cell phone calls occur indoors. So Bruce, the question for you is, yeah, it's neat when you design from scratch, but how about if you have old hospitals, like 80-year-old hospitals? What's the challenge of getting, and what's the expectation that it'll work in the new and the old hospitals, and how do you get it in?
So that picture is one that'll be there in about 2030 as we finish the seismic compliance upgrades that are required by the state. And in the future, actually, that the old building that is in the foreground gets demolished. Makes a lot of people nervous at my campus when we are talking about demolishing things that they have lived in for 20, 30, in some cases 40 years, and it is sort of their home now. So as we've looked at how do we progress from today, which is the building that is on the most northerly building in that picture, I guess you can say the northeast in that view, is the building that's under construction, is the first phase of that replacement hospital. And so we have looked at how are we going to properly put our systems in and put them in a location that means you don't have to move them. Put the hotel in a home that it can reside for a very long time, so that as we do modifications, demolition on the campus, and move to the future, it is there and it is permanent. It is a struggle if you put it in a temporary location and have to relocate it. The carriers don't like that. We don't like that. It means additional cost to us. So we have developed a strategy on where is the hotel for the service providers, where is the primary home for the wireless network going to live, not having the opportunity, as Paul did, to have a brand new building. As Ed said, we have to really think that through very carefully, because it does have to be able to expand and move with the buildings. So that first tower, we were lucky enough that we had some space in it that was really not usable for an entire department, that was available for us to establish as the head end for such systems. And because it has connectivity to the rest of the buildings from now and into the future, including outpatient buildings, it is the ideal central spot. Today it doesn't look so central as people come onto the campus, but it becomes the center of the campus in the future. So we have architected the system so that the head end of the system is in its primal location. It's in the best location for that movement forward. And recognizing that over time, even systems that are in the old building that will be there may only have a 15-year life, but they are intermediate steps to the ultimate goal. So you do have to consider where these systems live, how they interact, and how they maneuver over time. And that's a bit of the challenge of building on campuses where, I like to use the model of Walmart, where a Walmart can close, remodel, rebuild, reopen, and everybody reappears. In healthcare, you have to maintain 100% operations while you do those rebuilding opportunities. So this campus happens to be a 41-acre campus, very congested, and yet by state law, we have to rebuild the whole campus in situ while we continue to operate. So we did have to go through a development study of how would we do that. You know, there are always going to be differences of opinion on whether you are right or wrong in that solution. And I'm sure people who sit in my chair 20 years from now may look back at me and say, gosh, that guy was an idiot. But nonetheless, we have looked at how do we architect the system so it is a living system and is always operational. So it has been a challenge.
So who expects their cell phone to work when you're in a hospital? So one of the challenges is, what's the relationship between the PCS cellular carriers, the AT&T, Verizon, and Sprint, both inside the hospital and outside the hospital. Because I'm here to tell you that if Scott does his job right, the need for physical space will go down. Because we'll push care out of the hospital and there'll be more infrastructure independent. But that requires ubiquity, and you can't achieve ubiquity unless you use wireless. So Paul, be careful. But why don't you say a few words about what's it like partnering with the carriers as we go into this wireless health future?
I'm glad you asked that because you're absolutely right. I think it is extremely important to have that capability. And I'll give you an example first before I answer that question. As part of that nurse call and alert management system that I talked about, the next stage for us is to start notifying physicians of certain alert conditions on their smartphones. Well, I can't do that unless I have total coverage inside and outside, total cell coverage. So that's a challenge. I was at a conference last week. I was on a panel in Los Angeles, and I asked the audience how many of them had a distributed antenna system installed in their hospitals. And it was about 150, 200 people. How many? And about, I don't know, maybe 10, 15 people raised their hand. Then I asked them, I said, well, of those of you that have it, how many have all carriers operating on that distributed antenna system? Nobody raised their hand. Nobody. And that's part of the issue. We're very fortunate, but boy, I'll tell you, it took a lot of hard work. We're going to have all 4 carriers on our distributed antenna system at Palomar, at the medical center. But a real challenge, and especially since they paid for their equipment, we didn't. And we're a district hospital, we can't guarantee business for them either. So, and that's the other part of it. You know, they want the business. They want a guaranteed number of cell accounts if they're going to install their equipment. But we have it all. So we have 3 of the carriers that have base stations installed in our central power plant, and then we have one that has a repeater solution. So once we have all of them there, we can do some pretty neat things in terms of mobility and really start to push out then because we have the communications inside with some of these applications. But it's not without its challenges. One of our carriers came in and geez, I mean, you know, they said it was a disadvantage that our DAS had been designed prior to the construction. I was surprised by that it was a disadvantage. So we had to have the engineering firm come in and do a lot of additional studies and work with this one particular carrier to make sure that they were satisfied in terms of the signal strength and that there wasn't any leakage outside the building, because they were concerned about us knocking communications out for people outside of the building because of the signal strength in the building. So that was kind of a surprise as well.
Well, that's such a well-spoken goal of our mission, and that is that wireless inside that hospital should be as controlled as electricity, where you remove the barriers to adoption and innovation. So Bruce, what do you think is the most valuable wireless service to the hospital inside the hospital?
Well, if you had asked me that question 2 years ago, I would have probably said the Wi-Fi. But as I look at where is technology going, I do recognize that the wireless service, or the DAS side of it, is going to become very valuable. And the reason I think that is, and we've had this conversation many times, as you look at the carrier network and where are they going, and what is the opportunity what's the opportunity scan they have. So most of us have at least one cell device. Many of us have two, if we're only limited to two. We also may have our iPad, which has a cell service. And so the carriers are looking at the market differently now, along with the vendors of the various medical devices. So if you can, within the medical realm, have a device that lives within the hospital, that when you step outside of the hospital, hops onto the carrier's network, when you go home, is also then hopping onto either the home AP or the 2net system that Qualcomm has or some other system, so that it has that flexibility to always communicate back to the caregiver to exactly what Paul's talking about in his building, extending that beyond that hospital environment. So the hospital is now a place for extreme acute care, but the care continuum continues outside the walls of that building. It becomes a much greater opportunity financially, as well as for the caregivers, for them to be able to monitor and maximize the information that they are receiving from the systems that are installed with, on, or in the patient.
Bruce, you're a facility guy.
I know
Are you a really good facility guy for understanding that and enabling it? My theory is, if you don't trust it in the hospital, you're never going to trust it out of the hospital. So Paul is probably one of the leading CIOs in looking at the value of data and the value of business intelligence. So will you expand on Bruce's comments on the obligation you're going to have as a CIO for staying connected with the patient outside the hospital?
Sure, and I'd like to answer that a couple of different ways, but one is that when you look at where regulation, where the government's taken us, penalties for readmissions, we're not going to get paid for that. Accountable care, so wider episodic care involving more providers in that episode of care, and moving that care out of the acute care setting. I mean, I think it's a trend that we see that we have that's been progressing since about 2008. Acute care admissions across this country are down, and they're going to continue to move down as more care is provided outside of the hospital setting. And I think the as you said, Bruce, the wireless connectivity we're going to perfect it in the hospital, but it's going to have to be ubiquitous outside as well, and right to a patient in their home. If we're going to be able to control readmissions, if we're going to provide that episodic care over wider episodes involving more caregivers, so they have to be ubiquitous. And then to answer your question about, now that we have electronic health records, I mean, we're finally getting there. It took a long time. At Beaumont, when I was at Beaumont, we implemented our first electronic health record in 1983, and it's taken that long to move everyone there, but we're getting there. Well, once we have all of that information, all that data, and it's data right now, it's not information, so when we have all the data, what are we going to do with it? How are we going to leverage that? And today we have data warehouses that the information's a day old, a week old, a month old. That's not going to help us. I mean, it can help us for some retrospective business analysis, but I think the game changer in this industry is when we are going to be able to take and turn that data into information to improve the quality of care. We have to get there. We have to be able to use it. And what that means is that it's got to be on a real-time basis, or near real-time. It doesn't have to be exactly real-time, but near real-time. And I've seen examples of this in between my
my tenure at Beaumont and coming here, I spent a year with Oracle, and I traveled across the country talking to CIOs and visiting at hospitals like Mayo and Cleveland Clinic and Geisinger and Kaiser and Providence. And at Mayo, the CIO talked to me about a project that they were doing with real-time analytics, Ab Bengali. And Ab told me about it. What they did was they took these were patients that were on respirators for long periods of time, and of course, the plastic tubing, after a while, they're very susceptible to infection. And when they acquire an infection, they're too ill to fight that infection. So, it's a hospital-acquired condition that you want to try to eliminate. So what they did was they created a database and pulled in data from about 20 different sources. So all the laboratory data and medications and EMR data and telemetry data, and coming in from various sources. Within about a minute and a half of being real time, so they stuck an analytics program over the top of this database and looked for key indicators. And when they saw those key indicators, they would, through a dashboard mechanism, alert the caregivers. They practically eliminated those types of infections because of that. And I think that is going to be the future of healthcare. It's the only way we're going to get out in front in terms of that quality curve, I think. Real-time or near real-time data analytics. And there are people that are working on this right now. And of course, because we have that data, we can start to turn it into that information. So I think we're going to see a lot of that.
So with this left, I'd like to open it up to questions from the audience. And the deal is, if you have no questions, I have more questions. So I would encourage you to jump in.
That is important for us at Palomar Health. We're a district hospital that has a service area of about 800 square miles, and so reaching out into northern San Diego County and to the east is a strategy that we have to take advantage of. And the only way we're going to do that is through mobility and be able to connect those patients with their physicians remotely and be able to connect them with devices that can monitor their conditions in their homes. And we're starting to look at that. We're starting to look at some of that technology that would allow us to be able to do that. And I think that's going to be really important because I think in the future the community hospital may be a thing of the past because we can't afford to keep open hospitals that are partially occupied. You can't run a plant efficiently if it's partially occupied or your production is partial. And if you're in a community hospital setting, you're not going to be good at everything. I think there's going to be more regionalization of specialties in healthcare across the country. So I think what you're talking about, we have to get there. It's going to be extremely important for patients in outlying areas that have trouble, getting into these larger medical centers that are more regional. So that's a trend that's absolutely we're going to see.
It's also counterintuitive. We might be learning from other countries they're adopting mobility much more aggressively than we are. So, and they do it better than we do in a lot of cases. But the cold hard fact, there are more cell phones than there are toothbrushes in the world. So the macroeconomic of those chipsets really is enabling what we're talking about.
That's absolutely right, and that's one thing that bothers me that we really need to do a good job of. One of the things that I did when I was at Beaumont, I brought industrial engineers into IT. And started that in the late 90s, so that every project we did, we had an engineer that would help us with workflow redesign, and that engineer also, they're IT people don't have these skills. That's not how they're trained. And industrial engineers know how to measure, because you can't improve what you can't measure. And so we need to do our projects like this. We need to know what the impact is. You know, like for instance on our alert management nurse call system, we like to know, is it improving the customer experience? Now, Ben tells us it is, from anecdotally, he hears from patients that their service needs are being met more promptly. It's a good thing for them, but that's anecdotal. We need to really be able to measure that, and we've not done a good job of that. So that's something that bothers me a great deal. We need to do that.
I think just to follow up with that, in measuring it, you also need to measure revenue enhancement associated with that, because if you have a project that improves something but doesn't have dollars, it's very hard to get funded. Yeah, so measuring it, having the analytics to show the value add, whether that's in reduced labor costs within the facility. So to Paul's point about the method of contacting the nurse and appropriately assigning activity from the patient to the nurse's assistant or to the nurse or others is one of those areas where it really starts to improve the outcome and have a revenue enhancement method with it. Those are the types of things that truly we need to be able to bring together, because talking to a CFO and not having ROI associated with something, or just having cost associated with it in the future of healthcare, as we look at lowered reimbursements for doing the same thing we're doing today. So most business models, if you go out and say you're going to earn less for doing the same, many businesses would be very upset with that. That's the world we live in today. We are being told, not only by the government, but by everybody in industry, every insurance company, every business owner, that what we do is to assess and lower your cost, but don't reduce your service. In fact, improve your service and lower your cost. Now, can that be done? I think it can, because many of the means and methods that we have used over the years to provide that service have not been as efficient as they should be. It hasn't been a cost model that was based upon outcomes. It was a cost model that was fee-for-service based. So I think we have an opportunity. It's going to be a struggle, an educational struggle. It's a paradigm shift for the entire organization and the entire nation as a whole. So I do support exactly what Paul was saying, but recognize that there's a cost model that goes with that.
Yeah, in the back.
Yeah, hi. I don't know if this is on. So a few years back, my husband had a stroke, and we got him to the hospital. He recovered, and then he and I went on a little trip to the Grand Canyon. And as we were driving back, he got another stroke, and this is like right around Riverside. So in my mind, I had to calculate, because I know there's that 3-hour window. So I'm driving, he's stroking. And, I'm thinking, what's my next step? What am I going to do? So I managed to get him back to Scripps, which is our hospital. And then the doctor yelled at me that, I should have gone somewhere else. But I made it within the 3 hours. I made it back in like a little over an hour. So what in the future, what could I have at my disposal that would have helped me get him to the right place, make sure they were ready for him as we're getting there, and and maybe would he have something on him from the first stroke that alerted somebody that he was getting another one? Could I have something that I could just put on use my smartphone to say, hey, he's having a stroke, what should I do? Where can I go? What's the best way for me to go so that I'm not totally freaked out when I'm trying to get him to his, to get help?
Nice thing about this place is we got real doctors. So, and we got Adel from who's working the 911, enhanced 911. So
if you allow me to answer your question, my name is Adel. I'm a physician fellow here, and I'm also an EMS specialist. So we actually convened a summit here about answering your question about next generation health. So what would be able to offer you? Your car would be able to actually have a telematics where you can actually have a video where you'll be interfacing with a physician who's actually an emergency physician. And we'll be able to actually ask you to stop your car on the side of the road, dispatch a helicopter, jump and pick him up and take him to the right perfect place for him to meet that window within maybe a shorter time than 3 hours.
And is it possible
Yeah, that's a great question. That's a great question, and that's an area where I don't think we've done a very good job, quite frankly. We've got. Yeah. Right. That's right. We have in this country now right around 250 plus HIEs that are trying to do that, trying to be able to exchange information between various healthcare providers and trading partners. The issue is that we didn't employ the same standards in all of those HIEs. We got the cart before the horse. And of the 250 HIEs across the country, 25 of them are self-sustaining, which means that for most of them, when the grant money runs out, so do they. It's really a shame. It is really a shame because I think we could have made tremendous progress there by adopting a standard and doing it the same way, and we're not. So I know we've learned quite a bit, and I think maybe the next generation of it we'll get smarter, we'll get it accomplished, but we could have been doing it already. And the amount of money, the millions that we have poured into these things to not get results, it is really a shame. It really is. So we kind of blew it. But we'll get there. But that, I think, is the answer. I think we need that total portability, but we've got to have the standards in place, and everybody's got to play the same way. So.
I'd like to ask you a question about the notion of not having transportation. Do you think, in your experience, that there's a kind of a care unit or an acuity that weren't having transportation? The second thing is, do you have any surveillance areas, surveillance centers that you're monitoring?
Yes, there is a central monitoring room where they continue to monitor. It's not just through this alert system. The alert system is an enhancement to that. So it's getting prompt notification there, so that in the monitoring room they see it. It will also go to the nurse, and that communication will occur very promptly. I think it remains to be seen in terms of our experience and how this works. I would say so far, I think it's meeting the expectations. We have to fine tune it some more, but I think it's going to work well. It's a combination of that technology, but it doesn't take away completely the human element and interpretation. Ben?
since I was at Northwestern 20 plus years ago. Well, now we've moved the nurses out to the bedside. The difference is remarkable. It's quiet. There's focus of energy. Our concern was keeping eyes on the patient. The advantage of the central hub is visual line of sight. The line of sight is important. As the nurses with one patient, what's happening with the other? And we had internal debates. Should we monitor these patients with video? Do we need to if we move the patients out? And what we're finding is two levels. One, the nurses actually work in a distributed manner. That's not a given. Just because there's no centralized nursing station and we put alcoves doesn't mean people won't use them. People are social. We brought in ethnology section from UCSD. Looked at it and said, well, now nurses are pack animals. They're going to work together. They want to travel. It's actually working much better than any of us anticipated. See the nurses outside of the patient. And so a lot of the issues that we were concerned about, that line of sight, has been mitigated by the fact that the nurses actually are out of the patient bedside. But I think the two areas to, again, get back to your question, ICU and ED are the classic places in the hospital where you historically had a more centralized nursing functionality. Those med-surg units are more distributed. And the distributed model is now becoming very standard. You can see it here at UCSD, cardiovascular building, and you can see it at Wilson Hospital.
And on our side, we're actually nurse station, but we also have the nursing facility at the patient room as well. And as you say, some of that is a bit of a challenge. How do you change the habits and how do you change the methods of communication that have traditionally been there? And so we weren't quite as brave as Palomar was in just jumping off of that cliff.
Central monitoring, surveillance kind of a thing that goes on, and there's nursing there. If you put them together in a physical location, it's not necessarily apparent that you could pull them apart and have some people monitoring patients centrally that allow the nurses to move around. And if you did away with both of them, then I would really wonder.
One more question, and then we'll bring to a... No, otherwise.
What do you see the barriers and challenges to establishing continuity and continuum of services from the first responder through telematics, to emergency medicine, critical care, to long-term care? And how do you address that, let's say, in the next 3 to 5 years?
Well, I'll try to address that. We had a conversation this week with our leadership team about that very topic. And because you have a distributed model of healthcare right now where the acute care providers are separate from those long-term care providers in most cases, and the SNFs are separate from that, that continuum has not been something that has been well managed in the past. So on a fee-for-service type basis, it was episodic, and you were paid for the number of procedures that you performed. Whether you are a private physician, whether you're in a clinic model, a foundation model, whether you're the healthcare provider at the hospital, it was primarily fee-for-service. As we move to a model that is more based around that continuum of care, I think what you're going to see is a modification of what that healthcare provider looks like. The healthcare provider of the past being a singular hospital, we always thought of the hospital as the healthcare provider, now becomes a start to finish, if you will. Somebody who has responsibility for that care model throughout the life of that patient. They really now, we used to talk about how many lives you had in your plan.
But now that life is really start to finish. It's no longer a distributed model where multiple entities are going to be reaching in and doing that care. To Paul's point about the information sharing is going to become much more important. That's why as we talk about the wireless technology, we're going to have to set up systems to allow for that wireless technology to communicate not only with the primary provider, but also secondary providers, so that everybody can reach into that patient and perform the care at the appropriate time, at the appropriate cost.
Again, from the facilities expert. That's awesome. No, I cannot overstate how important it is. If it's designed in as a base building utility, hardly anybody challenges it. And if it's not designed in, it's really hard to get it in. Well, out of respect for everybody's time, let's bring this to a close. I want to thank Bruce and Paul for taking the morning to share your thoughts, and I want to thank all of you for your attention and your questions. So let's give these guys a round.